When I first diagnose someone with type 2 diabetes, we talk about what it means to have high blood sugar. We talk about the blood sugar effects, and then we shift to treatment.
A well-managed type 2 diabetic is eating healthfully, a consistent number of carbohydrates on a daily basis. They're exercising. They're taking measures to lose weight if they need to. If they're taking medicines that may increase the risk of low blood sugar, they're checking their finger sticks on a regular basis.
I was given my glucometer. I was shown how to use it. I was told how many times a day to use it. I went to a dietitian, and that made a big difference.
We look at diet, we look at exercise patterns, and we try and optimize those things and give someone a 3-month chance or so at lowering their A1C on their own.
If, however, your blood sugar is very high, your A1C is really high, I will prescribe medications initially.
People with type 2 diabetes can take any one of a whole host of medications. The easiest way to think about medications for type 2 diabetes are either to think about pills or injections. In terms of pills, there are medications that act at the pancreas level. There are medications that help your liver and muscle to use insulin better. There are medications that block carbohydrate absorption from the intestines. There are medicines that can help the kidneys eliminate sugar through the urine so that the body doesn't hold on to that sugar. And in terms of injections, there are two things. There's insulin, and then there are injections that are not insulin that mimic a different hormone in the body, and that particular hormone is called GLP-1. Deciding on the right course of medication therapy for a patient with type 2 diabetes is pretty complex. It requires taking a good history, understanding someone's own preferences and approach to diet and exercise, and you must take into account whether they're overweight or obese. The main goal, besides lowering blood sugar in the treatment of type 2 diabetes, is to control weight. And so initially, if someone just needs one medication, many times I like to start out with metformin. That's still considered by the American Diabetes Association to be first-line therapy for type 2 diabetes.
Usually I'll try to max out the metformin. I'll try to get to the effective therapeutic dose as long as the patient is tolerating it. And if that point, with max dose metformin and diet and lifestyle changes, the patient is still not meeting glucose targets, I'll add a second agent.
We like to start first with non-insulin medications, especially if the situation calls for that. But after 2, 3, maybe even 4 drug classes are being used and we're not hitting our targets in terms of blood sugar or A1C, then we need to talk about insulin. But I don't want patients to view it as a personal failure. It's just the progressive nature of the disease. When we think about the treatment of type 2 diabetes a generation from now, we'll be talking about drugs that have nothing to do with blood sugar. We may be talking about drugs that influence inflammation, drugs for weight loss. We may be even talking about a vaccine for type 2 diabetes, and hopefully even type 1. I think it'll be a very different conversation, but we also have to, in the meantime, use what's in our disposal for the treatment of type 2.